I think maybe we'll get started at 7:30. So good morning, everyone, and welcome to Sprott Surgery Grand Rounds. And the purpose of this round, as you know, we're going live with Epic at the beginning of June. And a lot of work has been done. And you know, there are things that are quite exciting and already set up, and some things that still need to be done. But I think one of the most important things is all of us have to be educated and transition onto the new system. And what we wanted this morning session to be is to be a very practical session where they'll show you the what we've called survival tips for surgical flow, what you need to know about working in the EPIC environment. So I'm going to hand over to Terry Stewart McEwen, who will introduce the rest of our Synapse leadership team in surgery.
Good morning. Thanks, Shaf. So as many of you know, it's always difficult because you are all experts in your field that you go from being an expert to a novice in one fell swoop in June the 4th. So we're really hoping that this opportunity today, which really is a holistic look at how a patient is going to flow from physician consenting them for surgery all the way to a post-op area, is a practical overlook of what it will seem for you in the new world. I do want to preface that this is a very big picture overview of that journey. So it's not comprehensive to what you may see as a nurse, what you may see as an anesthesiologist. We'll actually take the lessons that we learn from this practical review and really just to see how we can also flow those kinds of learnings to the different groups as we go forward in the next 57 days, I might add, before go live. I'd like to introduce in the order that we'll be speaking, Dr. Chris Van Dale, who's been just a huge workhorse in terms of the background of helping build the system for UHN as it relates to the surgical and op time module. Jesse Pasternak, who's been an expert user. He's a part-time surgeon, as you may be aware, and been helping with the heavy lift. He has lots of experience with the EPIC from his time at Women's College. Dr. Kyle Kirkham, who's also a part-time anesthesiologist. Oh no, maybe he might be a time and a half anesthesiologist, but really has done a huge amount of lift for us, including policy review and that sort of things. And then I would be remiss to not invite Connor Hastings and Zach Francis, who are our EPIC leads, who have just done a huge amount of work for the last 2 years helping us UHNI's the EPIC experience. So those people will help us walk us through. We'd like to get through the process and the flow, and then we'll take questions afterwards. So I'll open up to Chris, please.
Well, thank you, Terry and Shaf. Can you hear me all right? My internet was doing weird things. That's great. So full disclosure, I mean, I have not worked with Epic, and I'm really just the only tips I have to offer come from my exposure and lots of conversations with surgeons at the Ottawa Heart Institute and at the Peterborough Regional Health Center. And so that's my background with Epic. And I have an advantage of being an older surgeon, so a little slower to learn these things. So that gives some hope, I think, to some of the other senior surgeons. Just to sort of take you back, or let's move forward to June the 3rd. So you go to bed, and beside your bed, you have a dial telephone, and you have a contact book, a little Rolodex. And you go to sleep and you're on call, and you wake up at 4 in the morning and you look over to your bedside table, and my goodness, there's a smartphone there with a whole pile of apps on it. And you're looking at this, and you had a little brief course on it, and you're trying to figure out, how do I take this call? I can't even turn the damn thing on, or I can't figure out where the phone, how to even dial a phone number. So I think that's what we're facing. And as you know, of course, there's a huge number of features available in smartphones. And I think this is a really good way to sort of appreciate, I think, what we're going to be facing. And there's no question, Epic, I think by all of you, by now realize it's going to represent a major change. I've been around UHN or TGH and Toronto Western for, well, as a resident, including residency, almost 40 years. And I've seen lots of changes, and clearly this is going to be the biggest one I've ever seen. And as Sarah Muffet, our CIO, said, you won't know what you don't know until you go live. And I think we're all facing a certain amount of anxiety about that. But in my discussions with Ottawa and Peterborough surgeons, there's two themes that really have emerged. And the one theme is, as Terry mentioned, and Shaf mentioned, is patient flow. And it's really great today to see that we're really going to tackle this issue of patient flow. This seems to be, in other centers, clearly a high-risk area, and I think it's really critical that we make an effort to work through this. It's not going to solve everything, but at least we're going to understand things. The second thing is training, and most of you still today probably have not had your training, so it's really tough to appreciate what EPIC is like until you actually get involved in the training. I mean, the super users have just finished their training this week. And it's a bit, I'd like to give a big shout out to Vanka Hanley, who's done an amazing job in bringing her team together to help us with training. I've taken the surgery provider course, believe it or not, 4 times. I've taught the course twice, and I tell you, there's still things I don't understand, but I think it really points to the fact the training is critical. So I'm going to just end with 2 tips, and I think, or the tip I would have is, when you take your surgical provider course, that's really, consider that as a kind of a quick start guide. I think the expectation that a 6-hour course is going to make you an expert in EPIC, unless you already are, is unrealistic. You really have to seriously sit down, go through the exercises, spend time. And I'm not talking about 1 or 2 hours, believe it or not. I won't even tell you how many hours I put it, but someone wrote an email recently and said it's at least 20 or 30 hours. I know that seems unrealistic, but it really will help as we go live. The more you understand the program, because if you understand the program, then we'll be able to spend more time dealing with some of the patient flow issues and some of these interfaces, which we're going to struggle with. But if you don't even understand the program, it's going to be tough. So I think that's really an important tip. And as you go through the training and your exercises, the second tip I would have is write down questions, write down concerns, write down areas where you're worried about workflow. And then we're going to share this with our colleagues, like how to write notes, how to do consults, all these various things. There's all these great questions that have come up during training. And we need to somehow figure out a way to share this information with easy way. I know we all use SharePoint. There's so much on SharePoint. I personally struggle trying to find what I'm looking for, but we need to come up with a really simple way for the surgical anesthesia team and our nursing team to get some very simple questions answered. So finally, in the end, I'll just end that, this is about our patients in the end. And a bunch of my American friends are already on EPIC, and they absolutely love my chart. I have not heard a single negative thing about my chart. We may work in the background, and do all the things and struggle with things, but the My Chart feature for patients, they really think this is a huge shift forward. And finally, go back to our phone analogy. How many today would give up our smartphones? So I think we could not live with it. So anyway, I'll stop there, Shaft and Terry. Thanks very much.
Thanks, Chris. That's amazing. That's great. Thank you. And I'll ask Kyle and then Jesse to comment just as some opening remarks, and then we'll start the demo.
Thanks, Terry. I'm not going to take much time. We really are going to jump into the demonstration, but I think what you've heard is a couple key points already. Shaf has highlighted that a lot is done and more is being done. So to Chris's point about writing things down and communicating them in the team, I think as you all are exposed to the training and your practice and get access to the playground, you're going to find things that we've done that need to be tweaked and adjusted and fixed and improved. And we really want to make this a broader team that's bringing these things together now. You're all part of ensuring that this build is right when it goes live and ensuring that we get everything done the way we need it to for UHN specifically. So I just want to emphasize that I agree completely with Chris. We want that feedback. We want you guys feeding in to help us make this as good as it possibly can. So reach out to your physician champions, your nurse champions, everybody that has been working to make this success so far. The other thing I'll say is that in my lens on this project, historically, we all know that many of the things we do have been very siloed. They've been siloed between groups of providers, and they've been siloed even within our care from one phase of the patient's journey to another, where it takes a lot of work to track down information and find it and bring it forward and make it useful on the day that you're providing care. And I think you're going to see today some examples of where those silos start to break down, where we get to work at our best as a team between all of the different groups that are caring for the patient, where we really can leverage information that's entered by our surgeons in the anesthesia clinic, by our anesthesiologists on the day of surgery and on the floor, and by our patients even before they come into the hospital, so that we have that information at our fingertips when they see them. So we'll touch on a few of those things in the demo today, but I think Chris has highlighted that there's lots of wins that come with having that smartphone in our hand, and pay attention to those. We're going to have lots of learning over the next 2 to 6 months as we get used to the system, but I think the more we learn, the more we're going to be able to leverage all of those benefits. So it's exciting times, and I'll leave it at that and turn it to Jesse.
No, thanks so much. I totally agree with you. And, I've used Epic both at obviously Women's College, but also when I was working in San Francisco, and when they rolled it out there, it was also like, a big change. And I think what Kyle said about, the whole idea of having being able to generate data and generate an understanding of what we're actually doing is dependent on how much we engage with the actual product itself. So if we can spend time and input data, input our patient's information, then we'll be able to easily pull that back and use it both for QI purposes, for research purposes, and for whatever purposes you want. So I think that's really where Epic is really helpful in our day-to-day as academic surgeons and other healthcare workers. So with that, I'll just maybe grab Zach and maybe come on and start the. Yeah, perfect. So we decided to illustrate some of the basic aspects of Epic, because I think one of the problems is we hear Epic, we don't really actually know what it's all about and how it relates to our day-to-day work with EPR and other IT interfaces that we use on a day-to-day basis. So we figured we would just use an example of a patient. We picked a kind of a stereotypical patient that we may see, and we'll just go through from start to finish of receiving a consultation to the post-operative setting, and we'll do it relatively briefly. You may see things moving around in the background. If you have any questions, jot it down. We're happy to go through specific things in more detail after. But this is just a cursory look as to how to understand a patient care flow from start to finish. So essentially, we'll start with a patient that has been referred to, let's say, a thoracic surgeon with a lung nodule or a lung mass. So this patient has been booked into the clinic, and obviously the consultation was received, and it was triaged, and then it was booked into the clinic, and that's all done behind the scenes, and all the training that your administrators will be getting will help kind of solidify this process. But essentially, the patient has been booked in the clinic and they've been roomed, and so we're going to go into this patient. As you can see, it's pretty nice the way that your list for the clinic shows up, and you can just pick the patients as they come in. So this is the overview of what you'll see in the ambulatory setting. You'll have a bunch of tabs across the top. You have a bunch of other tabs, and a lot of these things are redundant. So there's the same. You can get to the same place through multiple different tabs. But essentially, the few things I'll highlight is that when you have a chart open, there's a few things that we want to have at least your engagement with to try and populate the patient's chart. Because as you know, many of us have patients that come from around the province and they are never seen at UHN. And so they're coming in for the first time and they've never have been in the chart before. And so we have to essentially populate the chart. And so some of the ways that we do this is to either do it ourselves, or actually we can have the patient come in ahead of time, or even send them a link ahead of time and have them populate some of the chart elements themselves, so they can put in their medications, they can put in their allergies and these types of things, and that's how we can actually have our chart populated a bit easier than us sitting down and doing it every time. So this is a patient that has populated their own chart. Their medications are on the right side. Which are there, and then there's something called the problem list, which is part of the intake. And the problem list is something that many of you may not be familiar with, but this outlines what are the active problems that the patient has, and this is a real good way to use to kind of highlight what the patient issue is, and that can be used for research purposes, for QI purposes, to try to pull patients out in your practice that have a certain problem, or even at the enterprise level. And so the problem list is really important to engage with, and then the visit diagnosis can be populated from the problem list. So here we're gonna take the problem list is going to be a lung nodule, I think, and yep, and the visit diagnosis. Maybe Zach, you can introduce yourself. I know you haven't spoken yet, so.
Yeah, no worries. Thanks, Jesse. Good morning, everyone. My name is Zach Francis. I will be kind of driving things here as Jesse talks through, and if there's anything that I want to call out that I think you will find interesting, I'll speak up, but otherwise it's kind of Jesse's show. But thanks for having me this morning.
And Zach undersays it, but he's basically been the driving force of the whole process. I don't know how he does it, but it's really an amazing feat. Anyway, so I'll just kind of go through from here. We've populated the problem list, we populated the visit diagnosis, and remember, when we have these things populated, then that will pull into our note, that will pull into the diagnosis when we make a case card, when we make a case request, it'll pull into the diagnosis in the OR note. All these things will all come from populating the chart initially. So it's really helpful if you have some time when you see the patient and you're entering the information in the chart to put some of this information in, because it really helps you in the long run. So we're going to populate our note. We saw this patient with a lung nodule. And so you can see it's really easy to just basically what Zach's doing is a dot phrase, and he's programmed this ahead of time to have a defaulted or a note which he's made, a template note, and this is all populated based on just the information that the patient has put in and we've put in this short time. So all this information is all put in. You can see the past medical history, the medications, the allergies, and then he's going to quickly just demonstrate a physical examination. So I don't know if you can, or can you do that? Okay.
So Jesse, in terms of like when the patient presents with the lung nodule, and then you got that pull down list of all the other possible thoracic diagnoses, is that a list that is already in Epic, or is that something that John Young did, or we have to do ourselves to create that sub list?
Good question. I'm not exactly sure what you guys have done specifically, but certainly you can have speed buttons there's a little wrench on the side, and you can just change the speed button so that if you have like a esophageal mass or something, you just basically tap the speed button.
Yeah, no, but what I'm wondering is that something we still have to do? Like Zach, see where it said respiratory lung nodule, and then it said search for diagnosis, and the common things there came up, right? The lung nodule, lung cancer, mediastinal tumor, pleural mass. Where did those names come from?
I can speak to that. We do set those at the specialty level. So different specialties have indicated what their most common diagnoses are. And so we can flag that dynamically based on your specialty in the clinic that you're logging into. But
this was done by Epic, not by UHN people. Like it's already there.
Yeah, it was done by the Synapse team in conjunction with UHN subject matter expert feedback. So we did it together, but no intervention required by any of you when you log in the first time. It'll just be there based on what you log into. Does that answer the question?
No, I mean, what I really wanted to know was this part of the work done at UHN. So every time you make a new build, the specific hospital does this work. Our Synapse team did it again.
Yep.
Okay.
So here, Zach's just showing that there's a little, you can actually draw a diagram of a physical examination. You can listen to the chest and say, this is where I listened to, and this is where I heard a wheeze, or whatever it is. So it's a pretty, and you can have some, it'll populate all these words by just clicking the left check mark. So you can see that it's, you've seen this, said there's a wheeze in the upper area or upper lobe or whatever, and then it just clicks in, and then it populates the wording. So then we'll just go down a little bit, and the assessment, you've already decided the template. And then this informed consent part can be part of a dot phrase. So if you are consenting somebody for a lung, let's say a lung left upper lobectomy, for example, in this scenario, then you can have a dot lung lobectomy or dot lung or dot lobe, and that will populate the entire discussion that you had with the patient, so you don't have to type it out or dictate it or any of those things. Keep in mind also that we have the dictation for about 6 months that you're used to, and then that's going to transition as well with dragon dictation. So you can just put your cursor at a place and then just dictate through Dragon if you want to have anything written in or typed in or dictated in. So at this point, if you're going to take the consent, then the consent is, unfortunately, we have a lot of things that we've unpapered in at UHN, but the consent is something that's still based on a couple of reasons, and Terry potentially can go into that, but we're keeping the paper consent right now, and that so you're going to have you're going to sign the paper consent, and then that's going to follow the patient through the patient journey. So then we're going to, at this point, we've decided we're going to do a lung lobectomy, for example, Shaf, and so we're going to do a booking of this patient for the OR. This is essentially the e-form, and it's the booking, and it's everything rolled into one. And so Zach's going to demonstrate that now. So he's going to go to the order sets and pathways, and he's going to see that there's a preoperative order set for a lobectomy that you've customized for this case request. And he's just going to fill some in. Maybe Zach, you can take over and just fill some of that stuff in.
Yeah, thanks, Jesse. So like Jesse mentioned, the case request, that is taking the place of the e-form. So if you hear case request, you can think e-form. This is where you're going to enter all of your information related specifically to the surgical booking. So the procedure, what it is, where you would like it to happen, patient classification, all that good stuff. Like Jesse mentioned, the example that I'm using now is one that is customized. So just a plug to go do your personalization lab. So here I've created a lung lobectomy personalized pre-op order set, which means that Shaf, we're picking on you today, but you're the default surgeon here, defaulting in at TGOR, and the patient class is going to be same day admit. So all that's just pre-populated from when I first made this. Obviously, laterality is going to switch. In this example, we said it was the left upper lung. So I'll just pick left as the laterality and indicate that anesthesia is going to be general. Like Jesse mentioned, we can pull forward any other documents.
For the date there, like, you know, for swims and everything, like my next OR date is whatever, is April 19th or something. So would I put in the date there, and that it means it's recognized like we currently do as a booked case in my wait list, or so that OR can look at it for smoothing and planning?
Yeah, that's absolutely right. So procedure date, if you know the date, you are free to enter that in. So if you know that you have a room on April 19th, you can certainly put that in, and the booking team will say, hey, Shaf wants to do this procedure at TG on 4/19. That's totally fine. And yes, that will factor into the smoothing reports. If you don't know the date, alternatively, that is also fine. That'll work just the same way as it does. So the date is optional. If you put it in, it'll factor into the smoothing reports. If you don't, it'll just go into the backlog as it does today, and we'll have a report for the booking team and the different admins to kind of monitor and see where folks are with respect to their breach dates and all that sort of thing.
Connor, if you know the date, Shaf doesn't know the date today, but next week he has a specific date. What does he do?
You can just call your admin, tell them what the day is, and they can get it updated for you.
So as you move through, again, the customization is quite good. So for example, like if I'm doing a thyroid, I don't give antibiotics, I can just have one of these customized for a thyroidectomy and it doesn't have antibiotics. We'll go down a little bit later, but doesn't have antibiotics checked. In terms of the post-operative destination, if I have a certain operation that I do all the time that always gets step down, then you can have that customized as well. So all these things are customized for the specific thing that you want if you're doing high volumes of certain operations. Here's the same pre-op checklist that we're used to. Not much is changing from here, except you can actually customize if you have a specific operation that you always want to have certain tests done, and I'll talk about that in a second, then you can actually have those customized for those, and those things will either print out for an external lab or to be done at UHN. They'll just be sent to the lab. One thing, sorry, did you want to, Zach, is there anything else specifically before I talk about the cosign, or?
Nope, I don't think so. I just was going to go through here and say that I had selected some of the some other orders that I always wanted to be acted on in pre-op. So those are all just picked, pre-configured. I can review those, make sure there's no changes. And if there's not, then we can just go ahead and sign the order. So that's all I wanted to say. And Jesse, if we want to do the cosign, then we can get into that right now.
Yeah, so if you are if your workflow dictates that your kind of admin is going to put the booking in, which is totally fine, then your admin can actually put this exact booking form in, and all you have to do, and it becomes active right away, specifically for booking forms. If it's for something else, like a medical test, then and let's say Shaf does PFTs on all of his lung nodules that he's going to operate on. So you've already spoke to your admin, and they've already put in a PFT, for example, for this patient to have done. So now when you're in the chart, you can actually go into your in basket, which is essentially just a little email basket that you have from all of the information and things that you have to sign off on, and your communication with other practitioners. And you can just go to this and just click accept, and then that's going to be signed off on. So maybe you can show how that's done. Yeah, and now it's signed off. So that's kind of how that would work from an admin office kind of perspective. So I guess now, did you have anything else, Zach, before we moved on?
No, I don't think so. That's the end of the what we wanted to talk through with respect to the clinic visit. I don't know, Kyle, if you wanted to kind of speak to just some of the things that are changing, some of the cool things happening at pre-admission clinic before we get to the day of surgery.
All of pre-admission is cool, but there's so much that we could focus on. We're not going to talk a lot about the anesthesia preparation, but just a reassurance that all of the historical safety nets that we have to ensure that our patients are optimized and prepared are still there. The orders that you enter in your surgical clinic are linked to the phase of care so that they're conducted either in the pre-admission clinic or, like Jesse said, if you're printing out a requisition for people to do those things elsewhere. So a lot of that has been pre-built to make sure that that happens right. If you don't put orders in, there are some tools in the pre-admission clinic, some decision support that's being layered on top of everything to help us ensure that our patients get the right investigations so that we don't have any gaps in our patient preparation. And then we've already talked a little bit about the data that's flowing through from one environment to the other. And Jesse highlighted how the allergies and medications can be entered. We are building tools for patients to help us inform the team around their past history, their past surgical history, and elements that should be in the problem list. So for our nurses in the pre-admission clinic using Dream, essentially they're going to still be bringing all that information together to ensure that we have a very comprehensive history for our patients and that we have a very good lens on what needs to be known for their surgery and for after. So for everybody else on this call, where you normally would have gone to the paper chart and looked for that Dream record, oftentimes I think surgical trainees and nurses and others find that to be a very useful tool to look for a comprehensive history for the patient. We will still have some of that being all brought together by our team to make sure it's all in the same place. I think,
Kyle, when my admin books that lobectomy, does that automatically generate a request for a pre-admission appointment, or is there still that additional step that they currently do?
So that's embedded in the case request order as well. So it's all part of the same process. You're not going to have to do parallel processing for all of that. And we didn't highlight a lot of the details in that case request. But for some of your colleagues, there's some really important stuff in there, like our hand surgeons. If you take Heather Balter, for example, if we do a peripheral nerve block on one of her patients where she needs to have motor strength during the surgery, that surgery doesn't happen because it's a failure. So a lot of that communication elements have been built into the case request so that surgical specialty specific things that need to be communicated forward are a lot clearer and transitioning across those teams in a better way now.
I'll also highlight also that the communication with the patient is actually much better from this perspective as well, because we didn't really highlight it, but you can every patient interaction. So when you're in the clinic and you finish the clinical visit or the consultation visit, all of the information that you want to give to the patient can be added to this My UHN or My Chart aspect of it. So if you give anything right now for a specific operations like handouts, PDFs, links, those things can all be attached to the MyChart communication. So so also, you know, in addition to the communication that you have with other practitioners, you also have better communication with the patients to hopefully minimize some of the calls and stuff that you get. So I guess now. Yeah, sorry.
Oh, sorry, Jesse, I was going to say, as we transition to the day of surgery, I just want to call out that the UHN portal people are migrating everybody. There's 250,000 patients that are on my chart now that are going to be migrated to the Epic, and they're all getting a link. So just remind your patients, they should all be getting a link, and they'll actually be migrated all to the Epic My Portal as well. Sorry, go ahead.
Yeah, so yeah, sorry, go ahead, Zach, if you want to.
Yeah, absolutely. So like Hal mentioned, you know, pre-admission clinic went well, a date was selected, and so we're kind of flashing forward in time now to the day of surgery. And what we really want to focus on is just what those orders that you place in clinic look like for the nurse when they're actually caring for the patient in POCU. And then we can also talk about some other haiku notifications and everything. So quickly right here, just for those of you that haven't looked at Epic before, these are referred to as status boards. This is essentially a color-coded list of all of your patients that are coming through by area on a given day. And so you'll all have access to this also. This is a nursing view, but you'll also have status boards. In fact, I know that we wanted to call out, you can see the emergency list for a day from your computer, so you don't necessarily need to go down to the OR to see what the emergency list is on a given day. Or what rooms might be running late. So just want to call that out. This is going to be kind of what nursing sees when they first log in. I'm going to go back to the POCU real quick, and we have our red-green day of surgery patient here. So the red color indicates that they have been admitted, so they've been checked in and everything like that. And when the nurse assigns them to a bay in pre-op, that's going to do a couple of things. That is going to update their case tracking event color to pre-procedure so that everybody knows where they are. You can also see which bay they're in. But the other thing that it's going to do for you is actually send you a push notification that says, hey, your patient has showed up, they're in this bay, and this is the time that happened. So on your mobile phone, you can be notified based on nursing documenting that event and acknowledging that the patient's been moved into the POCU. You can actually get a notification for that right on your phone.
Or if the consent's not completed as well, that will be showed up as well on your phone.
Yep, thanks, Jesse. So really wanted to just focus here without getting too much into the nursing screens. One of the first things that they'll be trained to do is go and review any orders. And so you might be wondering like, hey, I placed all those orders however many weeks or months ago in clinic, what happened to them? Well, they go into a status called signed and held. And so that basically means that they're bundled up together. They say, you know, Shaft signed off on these on X date. When the patient is in the preoperative area, that's when we want them to be acted upon. Their visual indication for that is this big yellow banner that says, hey, they're signed and held orders. You need to go release those. So that can be nursing orders, medication orders, anything like that. So I'm just going to go over here to the signed and held tab at the top, and I can see all my pre-procedure orders for this left lung lobectomy at TG that was ordered by Shaft. And I can just quickly select all of these orders here, say, yep, looks good, insert IV, the meds, release those. And then they'll be ready to be administered for medications on the MAR. And if it's a nursing order, then it'll just go to the active orders tab. Just wanted to quickly kind of call out what that all looks like from a nursing lens, and just show you kind of like how that appears on the day of surgery. Jesse, I don't think there's anything else we're going to call out here, right?
I just wanted to just highlight again those status boards because this is the view that both the nurses and the surgeons will see. You know, if you're coming in the morning and you want to see, you know, what your slate is, or you want to check it the day before, you can always go to the status board for the operative slates. Maybe you can go to the slate, the day slate board. Yeah, so you can see, what's happening in OR1, OR2, OR3, and then that's, that you can, check your list to make sure it's the correct order, those types of things. And then the other thing you can do is, let's say you're coming in the morning and you want to see, how many gallbladders Pasternak has because he's going to be canceled or something. You can actually check the OR emergency list to see what's actually on the board for the slate. So you can go to the emergency list. You don't have to walk down to that whiteboard at the general and at the Western. Obviously, you don't have to walk downstairs. So you can actually see it from your desktop. So maybe you can show that emergency slate.
Yeah, I'm not sure if we have any emergency cases this morning, but we can
Oh.
in our test environment. But I can see here real quick.
Anyways, the whiteboard, the emergency board, you can see from your desktop, so that's going to be a little bit easier. Here exactly, yeah. So it'll facilitate what the cases are that are waiting to get done, and you can go from there.
That's nice.
Okay.
So one other thing, the thing that allows the nurse to release the signed and held orders is the date, right? So then they can release it, and then it goes into the MAR and everything.
So with one of the things with phases of care is we don't actually need a date for it to become active. You can say based on the patient showing up and being in this procedural area. So like in with the phase of care there within. So once the patient gets to pre-op, then you can go ahead and release those. We don't want it to be tied to a date in case there's bumps or anything like that. So you don't have to go in and say like, oh no, the case got bumped to tomorrow and I need to update all my orders to be for tomorrow. Instead, we say when the patient is actually here receiving their preoperative care for their surgery, at that point in time, go ahead and release it. So we don't need a date. It's more that flag that says, hey, at what point in the perioperative journey do we want the order to be acted on? So that's how that works right there.
Good. Okay.
So I think at this point we'll just move on to the to the kind of perioperative post-operative setting. Is that okay, Zach?
Yep, absolutely.
Okay.
So I think we're going to log in as the resident now. So the surgery's happened. You're doing whatever you're doing, and the resident's going to go in and place some orders, and we'll show you what a note looks like. But I'll let you take it from there, Jesse.
Yeah, so this could be you, this could be the resident, fellow, anyone that's part of the surgical team. And basically, they're going to pull up the list or the patient that you're operating on, and I'll just let Zach show you. He'll pull up the patient list, and it'll go into the patient themselves. And then he'll first show you that he can get obviously all the information that you want from the patient, but then he'll go to the orders tab, and he's already shown that this has been a post-operative order set that's been made. And many of you may know very intimately, the post-operative order sets that have been made in your divisions. And to be honest, it's quite easy to make parts of an order set like an order panel, which is just a subset of an order set. But order sets have a bunch of logic in them, and Zach can explain that a bit more. I don't really understand it as well, but essentially it's got all of this information in it, and if you click one thing, it'll understand that you can't click something else, for example, and that's all built into the logic of the order set. So essentially, he's going through the order sets. These have all been customized for your division and even sometimes your section or your specific subspecialty, or they can be customized if they haven't already. And he's going to click off a bunch of things for the chest tube or for the wound care, and go down a little bit through the labs. These have all been defaulted already, right, Zach? I think you've already.
Yeah. So again, another plug for personalization. We do have the thoracic post-operative order set that you're all using right now. That was built like for like into the system. But again, as I was mentioning with the case request, we start off there, and then we assume that you probably have some of your own personal flavor you're going to add to it. So you can customize those. In this example, the resident has customized their own post-op thoracic order set. So all of this is already defaulted. So really nothing else to check off. This is going to be my standard as the resident or on behalf of the surgeon. This is what I want to do all the time. So I can pre-populate about 95% of this. With VTE prophylaxis, I just need to select a couple of things here really quickly, but pretty streamlined there because I've customized. One other thing that I do want to call out that I forgot to mention earlier that I know that has been kind of a question, at least in some of the circles, is if I make my own version of an order set, can other people get that? And the answer is yes. So if you have a pre or post-operative or whatever, for that matter, order set that you want to share with your admin or share with your resident, if you customize that, they will be able to actually search. So using Jesse as an example, I want Jesse's general pre-op order set. His resident can search for that and then pull it into their own kind of tool set so that they can see exactly what Jesse put in. So it doesn't only benefit you, you can also share it with your support staff so that they have access to that as well. But at any rate, I've gone through, like I mentioned, everything's been pre-populated, and so I can just sign these orders. And I have a couple of duplicate lab warnings there, so I'll just continue. And just need to override this.
And then after this, basically, he's going to show you how we do the OR note. And again,
Yep.
OR notes have all been can all be customized. And one of the ideas behind the OR note customization is that you really want to have a group that is doing similar work, and you want to have fields that you can pull out quite easily in discrete data. So, for example, here you can see all the blue things are discrete data points that you can pull out in a QI report or in a research report, for example. And those are things that you can get at really, really easily and quickly, even from the provider. So you can actually generate these reports yourself. You don't have to go through, health records or anything like that. So you can see the OR note's been populated with basically dot lobectomy or dot OR note lobe or something. And this is all pulled in, all this information. It pulled in, obviously, your name, Shaf. It pulled in the ASA status from the anesthesiologist. It's going to pull in the indications from your problem list and pull in the name and or the age and all the diagnosis, all that stuff. And then you're just going to fill out whatever needs to be filled out, and then you're going to press sign.
All right. I think that's everything we had planned explicitly to show today. Yeah, Jesse?
Yeah, I think so. I mean, at this point, the orders that you've done, some are going to be active right at the PACU, some are going to be active on the floor, and some of those things in terms of where they're going to go, post-operative location, can all be built into your defaults. One of the other things that's important to know is that there's a change in kind of our understanding of when orders are active, and we can actually, it's called something called phases of care, and many of you may have not heard that term before, but there's going to be a lot of stuff in when you're doing your training. They're going to mention phases of care, and the phases of care essentially just mean the different times that we meet the patient. So is it in the ambulatory setting, preoperatively? Is it in the OR? Is it in the POCU, PACU? Is it on the floor? So these are just the phases of care, and you can put an order in the preoperative setting to be active in the postoperative setting. It doesn't need to be active right away. So these are just ways of customizing when your order that you know you're going to need that order at some point. Why not put it in now as opposed to put it in then? Whereas now we have to kind of wait for that time and put it in at that time. So those are the phases of care idea that I just wanted to highlight.
Yes, hey, Zach, could you just explain how surgeons might, if surgeons want to dictate their OR note, is that possible? And not use a standard format? Some of the surgeons might want to do their own note their own way.
I can't comment on the dictation itself. I don't actually know how that's going to be populated, but certainly from a Dragon perspective, if you did not want to have a templated note and you just wanted to have the Dragon dictation, then you can just open up a blank note and put it into the as a Dragon dictation. I don't know if someone else on the line can comment on how the actual dictation, because it's only going to be available for 6 months, is what I'm told. So someone can kind of go over that.
Yeah,
My understand. Oh, go ahead. Go ahead. Sorry.
I was just going to say the dictation will be available for 6 months. Is the question about like how it's actually making its way into Epic? Because if that's the case, then we can follow up. I think I'd probably need to talk to the health records folks about it. But to Jesse's point, it'll be around for 6 months afterwards. I imagine there's not going to be much of a change for you. It'll make its way in.
I think, Zach, the specific question was if I finish that lobectomy and I want to dictate a specific note. I know how to use Dragon, so will I be able to just dictate an OR note in Dragon and it'll go into that slot?
Oh, yeah.
Yeah.
You just open up a blank note and just put the tab in there and just dictate from Dragon, and then it'll populate. Then you press sign, and it'll all pull into the chart as a discrete note from that encounter.
And also our specialists, like John has done a lobectomy note and an esophagectomy note and stuff. So if I wanted to use the standard one, I could pre-populate with that and just tweak it as needed, right?
Yep.
Yeah, that's just like the order sets, like Jesse was saying, you know, all the personalized stuff can be shared across divisions or even departments, or even cross departments if it's something that's appropriate for that. Some of that authority lies with you as a user. Sometimes those authorities need to be done by, you know, at a builder level, and so they need some oversight. But anything that is personalized is something that can ultimately be shared.
Rob, do you think you could enable people's mics and videos, please? And I think Marcus Bernardini has a question.
Just before we go to questions, I just wanted to say thank you, Jesse, for taking on the part of a thoracic surgeon. That's never an easy job.
You did well.
And
Thanks.
again, we'll take the questions. We may not have all the answers, but we will be. This has been recorded, and so if we don't get your questions, we will close the loop with everybody on the line. So I'll open it up to Marcus.
Thank you, Jesse, Chris, and the whole team for the work. You know, I think as you mentioned, Chris, when a new technology comes in, the first instinct is to try to make it as similar to your current process. And so, you know, I also have some experience at Women's College. And to your point, Jesse, Epic does provide a tremendous opportunity with the flow sheets and specific data entry that can be easily removed. But as we've been trying to do this for years at UHN, that comes at a tremendous cost because the instinct is to do a dictation. So to Shaf's point, you do a case, you dictate and drag, and that will be by far the most efficient and easiest way for clinicians to do that. But that won't provide necessarily the specific data endpoints that you're talking about that can be extracted. And it's the same thing in clinic. And I think that, you know, because, I mean, this is a surgical discussion and it's not specific just to the OR, I think one of the things that I think will probably happen in the clinic is that most people, although they could use the features that you're describing, Jesse, will default to just dictating a note on Dragon, doing whatever is necessary to close the encounter on the patient because they can't move forward until they do that. And I think if we're interested to move forward at UHN to take advantage of some of the other things that Epic has to offer, I do unfortunately think some resources are going to have to be put into that at the level of the clinics or even in the ORs, because otherwise I think it will be challenging. And the last thing I guess I'll just comment on that it's, you know, come to the attention, and I know this is not a new thing, and Terry will say we had discussed this previously, but there's two things when you introduce a new technology. It's one thing about just the workflow of the work that you're currently doing, but then it's another thing entirely when the workflow itself changes. And I think one of the real challenges in the clinic is going to be that currently orders are not, you know, inputted and done by the physician. That's just not the way it's currently done. And now the process is that is what's going to happen for every clinic visit. And before you can close a visit, that has to be accomplished. And I mean, again, having seen this at Women's College, where we do sort of, you know, less acute clinics and, you know, you can ramp down the volumes and do what you need to do. I think a lot of people, a lot of physicians are very, very concerned about this one element of things. And I guess one question for the team, in the US, where Epic has been launched in many places and efficiency in clinic is critical and also volumes in clinic are critical, do you have any comment on things that have been implemented in these centers to try to help that flow in clinic?
So the question is, Marcus, do you want just to know how we're going to deal with the flow in clinic specifically? Is that the question?
Well, I guess, I mean, the necessity for a change in workflow where the physicians are now putting in orders as a job that is not currently there.
Yeah.
Why
You
is
know,
that a
I think,
necessity
Marcus,
for you,
you
Emma?
brought up that, sorry to interrupt you, but
Yeah.
it's a point that we do need to make sure everybody understands that, like right now, I have a checklist of when I have a new lung cancer patient, there's about 8 or 9 things that I do on all of them. And, you know, some I don't do. So I check off on my list what I want, and my assistant puts it in for me. She can still do that, but I would have to second sign it on that sheet that Zach showed us on that page. So we had a lot of discussion about that because that is a huge change in workflow. But the solution is you can batch co-sign it. So at the end of your 20 patient clinic, you can say accept all, because that is the electronic verification that you take responsibility for what your admin put in. But it will be one click of the whole basket rather than clicking, 93 items that your assistant entered, and you don't have to enter the 93 items. So that's my current understanding of how to solve that workflow issue.
So the only thing I think,
Sorry.
Shaf, and at PMH, however, that job as you're describing for the administrators are from the PFCs. And if I understand correctly, there's a plan to eliminate that as part of the workflow. So that I don't think will be an option at PMH. Now, correct me if I'm wrong, Terry. I don't know if you know or if anybody or Gil
No,
on
so
the
I think,
call, but
yes.
I suspect,
So,
Shaf,
Marcus,
that may not be an option at PMH.
Well, I think these are some of the things. The first thing is what they tried to fix was the fact that, will someone put in an order that is not medically trained to be responsible for that order? And by you co-signing it, we fulfilled that legal requirement. The next thing was the first suggestion of how to do it was one that was just not tenable for usual workflow. One is that I enter it myself, or two is that I have to co-sign every single order. So the compromise was we batch co-sign them. So now the second thing is that's the Epic workflow thing. If PMH is deciding to pull away your administrative support, that's a separate discussion, right? If you had someone to enter orders now and it was going without your approval, only thing that's going to change is they could still enter it, but you have to approve it. But if the person who enters it for you is being pulled, that's a different administrative question. One that I was not aware of either, but two, it's not really an Epic thing. Does that make
no,
sense?
yeah, you're right, Chef.
Right.
And I'm just got it. I've got our notes are that we're going to call out the flow in PMH clinic and work with that team so that we can identify what that flow is. And as I said at the beginning of our talk, this was by no means an exhaustive flow map of all of your workflows. So thank you, Marcus. And we'll take that in and we'll actually get this all mapped out for you. And obviously all the clinics at PM.
But I think it has been very helpful to show us that haven't done our training, that we, what sort of to expect, and we can formulate areas that we might have questions and challenges and start working on them.
Shaf, could I just chime in a bit? When you mentioned the training, I think for those that have not done the training and looked at the screens, you'll appreciate that the screens are quite complex. There's a lot of things going on. So again, I'll emphasize a tip for the surgeons: if you can spend as much time as you can learning about it, being comfortable with the screens, that will help a lot.
And I mean, in your first 6-hour training session, is that where you get at least that look and feel? I mean, it looks kind of very easy when Zach's flipping around, but then I know it's kind of a busy and dense screen. There's a lot of stuff.
I think I think you hit the nail on the head, Shaf. When someone's doing it that knows it, it looks easy to follow. But when you start doing it yourself, you have to sort of, and you'll follow along with your trainer and you'll appreciate it. It's not quite as easy initially, but once you get used to it, I think it starts coming. And every time I've open a screen, I find something new. So I do think it can happen, but I'm an old surgeon. 6 hours was not nearly enough. And by the 3-hour point, most of us were exhausted.
Yeah, but Chris, you know Shaf. Shaf just wanted to pick up that phone and be able to
Good.
just do it without any instructions. You know that's how he works.
Well, I can tell you one thing is Chris Findell taught me how to do a perfect coronary anastomosis. I never thought he'd be teaching me how to do Epic. Who knew?
Any other questions for the panel? As I said at the beginning, this is actually just a quick overview, and I really want to thank Zach and Jesse and Kyle and Connor for this amount of work. We can absolutely do this again, and we can actually start calling out some very specific workflows. And we are going to film this, by the way, or video it, sorry, so that people actually can learn, as we said, from the communities of practice, so that as people are learning, they can start to learn from each other. A few questions, Shaf?
Yeah, so we have a couple more minutes, and I was just wondering, maybe Zach or Jesse. So we went through the whole surgical episode. So from discharge, like my standard discharge for that patient would be they'd be discharged home on post-op day 2, and then they have to return to clinic with a chest X-ray in 6 weeks. So is that sort of also automated there? Is there a discharge screen? I don't know if you can flip it up, or has that pathway been done too? And then there's also standard follow-up for lung cancer, every 3 months for the first year, every 6 months, second year, and so on.
Also, just talk about the post-op first. So John Young's been great in terms of customizing that for your specific specialty. But for example, for my specialty, I'll send home a thyroidectomy and I'll want to get blood work before I see them in the clinic for sure. So it'll print out a blood work rec with specific instructions of when to do it at the time of discharge through the AVS. And you can even have it so that there's customized even further where you have the blood work for UHN, or the blood work for an external lab, or the X-ray or whatever. So that prints out as well. And then in terms of follow-up lungs in the outpatient clinic, then that's essentially just you can do it in a few different ways. There's a smart set you can have, or other types of basically framework that you can use to have all customization. So all you do is pull up the chart, you put your specific smart set for that specific issue. So if it's a lung cancer or whatever, then that will populate the chart from a note perspective and from an order perspective, so that when they leave that day, the AVS will clearly show, make sure you get an X-ray before the next appointment, or whatever you decide to customize it to.
Right.
Thank you. Peter, and then Alan.
Very quick. So first of all, I just wanted to say good morning and thanks. Very, very impressive group, and terrific surgical champions, and Kyle, you and the anesthesia group working with them. I just wanted to follow up a little bit on the training. There are so many possibilities, and I think Chris and others have given you, a really nice overview of the training opportunities. Based on what I know about surgeons, and I'll give you my personal experience, I think taking Chris's point about doing the basic course, going through it, getting your sort of best effort to familiarize yourself, if you haven't used Epic before, with the various functions and the screens, and then I would say going right into the user setting lab, which will take you into the production environment and allow you to use your own login credentials, use the various tools that have been built by the working groups that are there. Maybe a little bit painful, but it'll have you in the real environment and allow you to do some of the personalization that Kyle and Chris and Jesse and others. It'll also expose to you, if there are any areas that you're struggling with or you don't understand, you'll get an opportunity to identify those in the user setting lab and have someone to help you walk through that. So bottom line is, and I defer to my colleagues here, I'd say if you really want to do the high impact stuff, go right in, complete your training, and then get into the user settings as soon as you can. And then you can also look at, there are a few minute videos here or there on how to clean up your inbox and all kinds of things. Probably get stimulated to look at that. So anyway, I just want to say thank you very much. I think this session should be part of the Intro to Surgery 101. Like, this is fantastic. You've done a great job. So anyway, thanks. Have a terrific day.
Thanks.
Thanks, Peter. Alan?
Yeah, hi, good morning, everyone. Great session, great work on this. I wanted to ask if you could comment on some of the specific benefits or enhancements that patients will have access to at home. You've already highlighted they will be able to have pre-created questionnaires that we provide them that they can put in info that will then help to populate their chart. Just two other features that just from some of the admin staff that have been doing the training that I was hoping that you could comment on are communication with us or with care providers via, email or secure messaging. Is that something that is enabled for all patients and that we should be aware of? And second, I've heard of a feature where patients can book their own appointments into your clinic. So is that actually how the process can work, or is it a feature that's toggled on and off?
I'll just call, sorry, go ahead, Zach.
I was just going to say, with respect to the second question, the scheduling, like patient self-scheduling, that is something that can be toggled on and off. I believe that right now, and I'll confirm this, but I think that we have it set kind of per clinic at the moment. I'll need to follow up with our outpatient appointment scheduling team, though. Sorry, Terry, go ahead.
Yeah, I was just going to say that that'll be a real change management workflow that we'll want to enable, but that would be something we would take on post go live for sure. In terms of the comment around the patient questionnaire, sorry, Alan, what was your first question? I'm sorry, I missed that.
Sorry, it was just about direct messages from patients to care providers.
Yeah, actually, that's going to the PAC, as I understand, because some staff already have communication email, but there is secure messaging within Epic, and it's just how it's going to be enabled. And Shaf, I think that's coming to PAC or MAC as well.
Yeah, I mean, the big issue with that was we had started developing the Vivify app to exactly do that, and Vivify integrates with Epic. Unfortunately, Vivify has just been bought out, and they've had decided to pull out of Canada. So we have to get another provider because that function is one of the weakest points of Epic, the asynchronous communication with patients. It's not there, or it's clunky or whatever, but we'll need to figure that out. So we're running out of time, but I think, this session is exactly what I wanted it to be. Thank you all for doing it. I think it gave us a good sort of look into where we're at, what we can look forward to, and what our concerns might be. We'll plan to do one more like this. I think, in about a month or a few weeks, we'll all be a little bit further ahead in our training and our understanding. So we'll continue to move forward on that. Thank you all very much again. Have a good day.
Thanks, everybody.
Thank you.